It was like snowing, freezing.
In
Like,
Hampton House?
house, it was like 80 some degrees. You guys were like the 8th floor. But she said,
I just-
is there like holiday sweaters and stuff? And like,
Oh my
just
God.
just sweating.
Yeah.
Because it was that.
Definitely. And then finally they.
Okay, before we get started, I have some announcements. Help people get settled. So, upcoming seminars. So this is our last scientific seminar of the academic year. Sadly, we're saying the best for last. So our next one won't be until October. So first Monday in October, October 5th, we will have Aisha Dickerson. She's an associate professor in epidemiology. Don't have a title for her yet, but I'm hearing Aisha, I'm sure. Will. Other upcoming things happening in June. Alden is giving a dean's lecture. Those who are not familiar, the dean's lecture is when you get promoted to full professor in the School of Public Health. You are invited to give a dean's lecture and you do whatever you want it to be. And it's kind of fun and a celebration and everything. So if you're able to come, please come in person to show your support for Alden. And the title is Validity is Not Good.
I'm gonna wear a jacket. Which I'm sure you've never seen.
Yeah. So I'm intrigued by the title. Okay, and then on June 9th is the JHADRC annual meeting on aging and dementia, and Alden will be speaking at that as well. That's in the Owens Auditorium, Unseen building. That should be a great day as well. There are several other speakers, it's not just Alden. All right. So today I'm
Can I give a plug? Can I give one plug? June 22nd.
sleep meeting.
Sleep and Circadian Research Day. You just search for Johns Hopkins Sleep Circadian. It should come up. It's a Google form. Register. Might be too late to get fed. I'm not sure, but try to register.
Sorry, I forgot about that one.
No problem.
I'm glad you said.
Yeah.
That's always a great event too. Any other announcements? Maybe I should ask. So today I'm very, very excited to say our speaker, one of our very own, Dr. Jennifer Deal. She has been here for 20 years as student and then as track faculty and then as tenure track faculty. So she's been through it all. She is, as a epidemiologist, also a gerontologist. She's currently an associate professor and also has a joint appointment with otolaryngology in the School of Medicine. Trained in the epidemiology of aging, Dr. Deal studies the effects of hearing loss on aging brain and how hearing loss influences cognitive function to inform strategies for the primary prevention of cognitive. But I will say also, I've had the privilege of knowing Dr. Deal for almost 19 years, almost 20, and it's a real pleasure. She is epidemiologist supreme like no other. Fantastic teacher and really just a great collaborator, and we're just thrilled that she is here to talk about where do we go from here, updates from Cochlear Center for Hearing and Public Health. So thank you.
Again for that, and thanks for everyone for being here. I know it is the last seminar. I know it's a very, very busy time of year, so I do appreciate your attention today. I do think I probably have enough slides, and the way that I talk, I could just get going and keep talking for the entire hour. But if you do have questions, please feel free to interrupt me. I always think it's more fun when we have a conversation rather than when we just kind of try to barrel through all the slides. So we'll make sure we get slides before this, and I have that discussion if you'd like. So here are my disclosures. Nothing that will impact the conversation today, but very relevant to the conversation today. So as of September, I've taken over as the director in an interim position for the Cochlear Center for Hearing and Public here at the Johns Hopkins Bloomberg. So this is to get us all a little bit motivated for why this topic is even important today. I teach a course during third term on the epidemiology of sensory loss and aging. And we always start out that term by asking something very similar to this. It's asked in a slightly different way. But I'd like you to think about something that you enjoy doing when you are not here. Outside of work, outside of school, something that brings you joy and happiness. And usually that's pretty easy for us to think of. I really enjoy doing. But what I'd also like you to take a second to do is to think about what you really enjoy an activity or how. Anyone feeling brave? Would they like to share?
Can share. Like listening to music, not physical activity. That's not my cup of tea. I'm listening to music and doing nothing.
Well, good. So thank you, Cece. So it's listening to music, not physical activity, but listening to music and doing nothing else. So really being engaged. Set me up well for this talk. Perfect answer. It's a common answer that we get.
Bird watching, as many people know, so of course that's sight and sound intensive. And so thank you for this example. It brought it home in a way that never really has before.
Yeah. Thank you. I appreciate that a lot. Bird watching is a really fun one. And it just, as you said, it's both the visual as well as being able to hear the bird song as well. Or even sometimes it's hearing that bird song, recognizing what it is, and then trying to find.
Gardening,
Okay. And what is it about gardening?
in the space, relaxation, and times you have to, plants respond to you. And sometimes you have to move them around, and it's like a canvas for me.
Yeah, great. So we're talking about gardening, and that was really lovely. You said moving plants around, putting them in a place where they really respond, where they have the things that they need. And so in the way you described it was also almost like a little bit of a visual palette there. I certainly can imagine there's some very tactile elements to that as well. Yeah. Thank you for sharing. I will say we get the full range. A lot of students really do enjoy music, and we have the full gamut from listening to music to dancing to music to making music. We also have a lot of times food comes into play, which we haven't talked about yet here. But sometimes there's that social element of creating a dish and sharing it with others. There's the smell and the taste of it. There's the memories that it brings of those that we've shared that or maybe one recipe from. So that's something else that we commonly hear. And just as Karen, as you alluded to, exactly what this question was meant to elicit is how do we engage with that activity and really get joy from it? And really, I think that sets up the premise for why the Cochlear Center is doing important work and why sensory health is important. And as Jen mentioned, I've been here for a long time, trained in the epidemiology of aging at one of the premier institutes for the epidemiology. And during that course, and even at the time when I was first taking that class, we talked about the epidemiology of aging really as a discipline. We started in the realm of physical function. A lot of this grew out of the idea and recognition that as we age, certainly it's important to still think about primary prevention of comorbidities, but many people develop comorbidities as they age. And so the idea is it's not just about preventing comorbidity, it's also trying to make sure that we're maximizing function for those who have disabilities. So like I said, physical function, I think, is really where it started, and a lot of the great seminal work that's been conducted at the Center on Aging and Health here really has been around physical function. And frailties are really important area of work to this day. It didn't take long, of course, then to recognize that, of course, it's not just physical function. Cognitive health is very important too. And so the recognition of cognitive health came into play, and then we started to also think about the interplay between the two, physical health and cognitive health. I would argue more recently, we've really started to understand and really think about social function as another domain of function that we want to be maximizing when we're thinking about the aging process. And certainly with the pandemic, and even before the pandemic, the importance of social health was really starting to be widely recognized. It's important for vascular health, it's important for cardiovascular and all in addition to a number of other things, including. So I would argue no matter what domain of health we're talking about, as we age, physical, cognitive, or social, it really is important that we have a healthy brain in order to be able to engage in these different activities. Our brain, though, is encased in our skull, right? So when we think about how we get information into our brain, to keep it healthy, to keep us engaging into those activities, it really is through our senses. Our senses are what allow us to connect with the world around us. They allow us to connect with other people. They allow us to do those things that bring us joy. And so that really is kind of the underlying premise. Cece, I said you set me up really well. I was kind of thinking through kind of the main points that I wanted to highlight today. And then thinking back to this question about what do people like to do and how so many people do enjoy music. So I'm going to take us on a little musical journey as we go forward today, starting with the great Barbra Streisand with her song, The Way We Were. So this line from the song is, memories light up the corners of my mind, misty watercolor memories of the way we were. And I want to start by talking about the way we were, because we have to know where we came from in order to know where we want to go. So I want to take just a really quick moment to talk about our history at the Cochlear Center. And part of that history is the need and why a center like this is important. Started out by kind of talking about all of the senses that is important to us at the Cochlear Center, but of course we really primarily started out in hearing. Hearing is our pain. So the most of the talk today will also focus on hearing. But when we think about hearing, there's a really high prevalence of hearing loss in older adults, and that prevalence increases as we age. So this is data from the National Health and Aging Trends Study. We have the prevalence on the y-axis, 0 at the bottom, 100% up. We have different age categories moving along the x-axis, starting with 71 to 75-year-olds, going all the way to those who are 90. The dark blue, which is at the bottom of the bars, indicates normal or typical hearing. The light blue next is a mild hearing loss. The green is a moderate hearing loss. And the yellow is a severe hearing loss or greater. So you really can see as we move across the age categories, those dark blue bars are getting a lot smaller. And in fact, by the time we get to be the age of 91 or older, it's nearly everyone who has some degree of hearing loss. And you can see, of course, the severity is also increasing with age. So when we think about hearing and aging, it really isn't enough to be thinking hearing loss, yes or no. We really need severity as well. So this is going back to our history. It really is incredible to me that we are 8 years into the work that we've been doing. This is just a local article from Johns Hopkins talking about how we were founded with a philanthropic gift from Cochlear Limited, which is the largest cochlear implant company. We were announced on World Health Day, which is March 3rd. You can remember that because it's 3-3. The 2 3s are like 2 little ears. And so we really have been going strong since that time. You know, we were really founded in collaboration and led by Dr. Frank Lin, who many of you know, an ENT surgeon who really has been done a lot of the seminal work in this area recently. And at that time, it really was given Cochlear Limited, given the source of their funding and their revenue, given that they really were able to take kind of a long view in terms of partnerships they were looking for, they recognized that just increasing knowledge around hearing health among everyone would ultimately help them when they're thinking about self. They'll help them with their bottom line. And so we really were fortunate. It's a single-use gift. But there are really no strings attached. So we really were allowed kind of the ability to decide what are the key ideas and key topics that we want to be. So Dr. Lin took a sabbatical with Apple last year. Starting September 1, he left this year to go join Apple full-time. So he has now moved on to industry. He maintains his affiliation with Hopkins. And so in August, I think it was around August 15th or so, I found out that September 1, I was taking over that role. So I've been in that role for not quite a year. Since the beginning, this has been our mission and our vision, and I would not change a single thing about our mission. So it is about something that is near and dear to my heart, which is training. So recruiting and training a generation of researchers, clinicians, and public health experts, study the impact that hearing loss has on public health, develop and test strategies to help implement effective policies for hearing loss. Our vision is to effectively optimize the health and function of an aging society, become the premier global resource for groundbreaking on hearing loss and public health. If it were up to me, this is something that I would change, at least in one minor way, which is I don't think we can do it all alone, and I don't think we should be. So here I would really say to become the first premier global resource. And I will say, you know, at the very beginning, we talked about those 3 domains of function: physical, cognitive, and social. I really do view sensory health as the 4th domain of aging that we should be including whenever we talk about the epidemic. If we're going to make that happen, we need a lot more centers and a lot more resources, really. So I think, you know, what we've done at the Cochlear Center and the way I'm kind of thinking about it currently is not that different from the way that we've done things in the past. So first and foremost to our mission is training. We need those individuals who can do the work and carry it forward. Will always be central to our mission. We need the research. We need to generate that evidence to drive change. And of course, everyone in this room, we're in public health, not just we want to answer really important questions that will make a difference for the lives of the serve. And so advocacy is so important to our mission as well, so that we really can make that public health impact. So moving away now from Barbara and thinking about our history, moving on a little bit to our training mission with the Jackson 5 ABC. So you went to school to learn things you never knew before, like I before E except after C, and why 2 + 2 makes 4. I won't say a lot about our training mission, but I definitely wanted to include it again because it is so central to what we do. The diagram on the left is a little bit out of date, particularly some of the language, but at its heart and what we try to do is still represent. So we try to create learning and training and mentoring opportunities for students who are here at Johns Hopkins, and that includes the Bloomberg School of Public Health across all departments, but it also includes the School of Nursing, the School of Medicine, the undergraduate campus, a lot of other individuals as well. We also try to think about learners who are in other institutions, but still at the same level of training. So for people who are early in their career, how can we connect them with people who have complementary expertise? How can we train people in both a public health approach as well as understanding really the fundamentals of hearing health and treatment, particularly for hearing health? How can we connect people so they find their collaborators now moving forward for the So really targeting people outside of this institution, but people kind of early in their career paths. And then the other thing we do is really try to target, again, people outside of this institution, but people who are more established in their training. So these are people who already are practicing as an MD, already are working as a PhD trained epidemiologist or biostatistician where they are. But maybe they don't know yet really anything about the public health approach, the way that we try to address questions, or maybe they're trained in public health but don't have the expertise related to hearing. So we really try to create learning. And then on the right, we do have a massive online course that's available on Coursera, a public health approach to hearing loss and aging, in addition to some of these other training. These would be free training opportunities. So just summarizing, again, in those 8 years, we've had around 40 students here at Johns Hopkins University, again, from undergraduate, MPH, master's, MD, PhD training programs, as well as postdoctoral fellows. The program that I mentioned that really is targeted for people who are early in their careers, really for intense training, is something that we call our Summer Champ program. It is a play on summer camp. It's the Cochlear Health and Aging and program. And this is again where we really target people outside of the institution to try to bridge those connections across disciplines. And so to date, we've trained 20 AUD students, so audiology doctorate students, PhD or MD students. Our 2026 program is coming up at the end of this month. What I will say with this program too, is that it really is designed to be very, very intensive training. So we bring people in around their research interests, and within a week we write a paper. And we also sponsor them to present that work at a scientific conference. One of the things that's really amazing about our funding is that we don't have some of the limitations that you would if you were funded solely through the National Institute on Health. So we are able to bring in visiting students, typically PhD students from other universities. We just had a student leave us. He was here for about 4 months, joining us from Brazil, the University of Sao Paulo. He's getting his PhD in audiology and speech pathology, really, really interested in public health, but there just weren't the opportunities for public. So he was able to come work with some of our faculty, training there. And the Fellows Program is the program that we have that's designed for people who are established in their career. Here we have a larger reach because we take larger cohorts. So to date, we've trained over 200 fellows. We conduct this work. We started out by having individuals come here and realize that might put limitations on the ability of some people to participate. In particular, as we moved everything online during the pandemic, now realized, okay, we now have an online program and the opportunity for us as faculty to actually go to visiting institutions for some training. We've been to Shanghai, Taiwan, Mexico City, Thailand, and Latin America. And so we are now in the process of next fellows program, I think will be, I know it's a hard life to have to. So that was just a little bit of the training. I'd like to move now to the late great Marvin Gaye with his song, What's Going On. Talk to me so you can see what's going on. And to me, I chose this song because it really exemplifies a lot of the research that I try to do and at the center. If I were to kind of put a timeline to the research related to hearing loss, and particularly cognitive decline and dementia, I think that's really most recently where this work started again, where it kind of ignited a lot of people's. But we weren't the first. And to my knowledge, the first study that was published was all the way back in 1989. Relationship of hearing impairment to dementia and cognitive dysfunction in older adults was published in JAMA, a case control study, so very high quality journal. But then it just sat there. It sat there for nearly 20 years. Until Frank published his first paper. This was using a longitudinal study on aging data, on hearing loss and incident dementia, and that was all the way in. And then I was just kind of working on finishing my PhD at that time, in the process of transition faculty here at the school. And so my first paper with Frank was published in 2015. It was using pilot study data from the atherosclerosis risk and community. And I think what's so important, and one thing that I really wanted to highlight here, of course, for those of you who know Frank is very charismatic, and he will tell everyone and anyone who's interested in listening about why hearing loss is important. He really did due diligence with making sure he got out there to share that news broadly. So he was going and talking to the hearing experts, going to those conferences, not just to public conferences, for example. But I do think there was something else that was going on. And so when we start to think about dementia and cognition, of course, we know that research is cyclical. But at that time, when we were thinking about dementia prevention, all of the messaging was around midlife. And that was because, right, the trials that we had done, we'd not seen anything make a difference in late life. So all the messaging was, well, take care of your hypertension in midlife, and that'll protect your brain health in late life. Take care of your diabetes, right? And for me, why all of that was very important, and I was actually exploring some postdocs to go and do some more of that work, was really, really unsatisfactory. We had this whole group of older adults going to be aging in to the time when they were really at risk for dementia. And our messaging was, we can't help you. You should have done something sooner. So that's really why I started getting excited about hearing loss too, and why I reached out to Frank. The next GSA is in Washington, D.C. That's actually where Frank and I met for the first time. We connected here at Hopkins, but weren't able to find time in our schedules to meet until we were there. Thanks. But it really was, I think, because there was nothing that we could do in late life, it really did, kind of catch on. And I haven't gone back and looked, and I really should. It's been, I think, about 3, maybe even 3.5 years ago now, where I just kind of took a peek, like, what was the number of papers that were being published in the scientific literature available indexed on PubMed, took place before 2011 versus after 2011. And at that time, even 3 years ago, it was over a 300% increase. Once this caught on, it really caught on. And I do think another thing, and I really do give Frank credit to this as well, because he really did make sure to make those connections that helped ensure that we were included. But the Lancet Commission had their first commission on dementia prevention, intervention, and care that came out in 2017. So for the very first time, hearing and cognition had been studied in other disciplines for decades, for a very long time. It was more in auditory neuroscience spaces or psychology spaces. It wasn't really in the public health realm. And by getting hearing loss to the Lancet Commission, now we're moving it to a public health realm, and really where a bunch of dementia researchers are seeing it and getting excited about it. So their first, report estimated about 35% of dementia cases globally could be potentially preventable because there are potentially due to modifiable factors. And hearing loss again was included for the first time. And not only was it included in terms of the population attributable risk, or the percent of cases, dementia cases globally, are potentially attributable to these different risk factors. Hearing loss was number 1. It was 9% compared to everything else. And that goes back to the high prevalence of hearing loss that we've talked about already. Also, the relative risk from their systematic review and meta-analysis was 1.5. So you're talking about a relatively strong. And like I said, since that time, the literature really has exploded enough to now where we have a number of systematic reviews and meta-analyses, and all the observational studies, they generally agree. So here is one study, another study, and then here again, citing the latest report in the Lancet Commission. And so if you look across any of these studies, they will tell you on average that in these studies, hearing loss is associated with increased dementia and so going back, this is now the most recent update of the Lancet Commission report from 2024. We've moved from a 9% population attributable risk to a 7%, but up with high low density lipoprotein cholesterol. We are still at the top. I will say very exciting for us as well in the 2024 Lancet Commission, for the very first time, vision loss was also included. What I will say, though, is that the methods that the Lancet Commission uses to calculate those population attributable risks have some very strong assumptions. And so many of you, I'm sure, remember Jason Smith, who graduated just last year with a PhD in epidemiology. He was really interested in trying to understand the best methods that we can use to try to calculate these measures. This is again data using the National Health and Aging Trends Study, and what he estimated overall was a much higher, around 17%. So we're used to citing those Lancet Commission reports, but I just put it out there that the proportion of dementia cases, if hearing loss truly is a causal risk factor, which we don't know, but if it truly is, the proportion of cases might actually be higher. We just want to go back though and talk about some of the limitations of the Lancet. Even though it seems like this might be a question that's been answered, I really think that the field is still quite nascent. So for the Lancet Commission, and this is the most recent systematic review of it, We'll start by highlighting that on average, the hazard ratio estimated was 0.3, so about a 30% in risk of dementia associated with. But I will also then highlight that there are only 6 studies total were included, despite that really large number of studies that have been. So why is that? And the number one reason is that the Lancet Commission has stricter inclusion criteria than any of those other systematic reviews. So it requires a prospective follow-up, and I think it says at least 5 years of follow-up. I think probably the biggest limitation is that it wants an objective measure of hearing, and so that's audiometry, and we just don't have many studies of aging that yet have sensory health measures. In addition, they want to make sure that we're adjusting for benefits. And I know that seems obvious to us in the public health space, but again, a lot of this work has been done in disciplines where that's not the same methodology. But what I will say is, even though they have these strong inclusion criteria, their inclusion are at least some of the participants had objective measurements, and there's at least one study in there where not everyone did, and some of them are clinical measures that really are not very valid or reliable. So for example, the whisper test, which is where you stand behind someone and whisper to them, maybe they don't have hearing loss. But you can imagine, again, the validity of the. So even though they really do try to have studies with audiometric measures, not all of them have. There's also a broad age range in some of these studies, as young as 19 years old, and at 19 you are nowhere close to being at risk for dementia in older. And so the amount of follow-up time that we would need to see if you actually have the outcome of just isn't there. I really honestly, though, think the biggest limitation is ABC study is 3 of those 6 studies. And so 2 of those were not designed to understand whether hearing loss is associated with increased risk of dementia. They were answering other questions. One was looking at multisensory impairment and dementia, and the other was interested in the joint impact of depressive symptoms. And we all know in this room, when you have a different research question, you design your study very differently, you're adjusting for different factors. And again, this is using the exact same data. So I really think that's one of another thing that changed in the initial meta-analysis is that they averaged the associations across all levels of hearing loss. And when we start talking about a mild hearing loss, people may not need hearing. So if we're talking about correction, it may not even apply to the overall question we're trying to. So mild loss in particular, warrant treatment or to impact cognitive decline. And I think we've seen. I will say there's a number of limitations of hearing dementia associations in general, not just part of that meta-analysis. One is just the very small number of studies. And again, I think the major reason why we're seeing this is that we just don't have audiometry integrated into enough studies of aging yet. And that is something that we're certainly trying to do. Really, when we talk about the diversity and representation of individuals included in these studies too, it is not diverse, it is not representative. Mostly high-income countries, mostly US countries, mostly white participants. And so I think these are things that we might commonly see, but I have a couple of limitations I just want to highlight that really I think are specific to hearing and really specific to public health researchers do hearing health. We tend to think a lot about, oh, people who study hearing aren't trained in public health methods, right? So they may be doing things in a different way. But I also think we have some real lessons to learn from our colleagues who are trained in hearing health, and that just hasn't been broadly integrated. Again, we need to get sensory health as that 4th domain function when we're talking about that. The first big limitation, I think, is just misunderstanding how hearing works. I think hearing is a volume issue. It is not. It is clarity. It is not volume. So when we think about hearing, there are 2 steps, simplifying a little bit, but it's generally true. So the first step is what happens in the ear. The second step is what happens in the brain. So we have peripheral encoding of sound in the cochlea, in the inner ear. Introduced into a neural signal, the neural signal sent to the brain where it's decoded and the brain figures out what it needs to do with that information. Many of you know my good colleague, Nick Reed. This is an example that I have borrowed from him that the sentence, you should go to the pharmacy before you go to. With an age-related hearing loss, we lose access to some sounds, but not all sounds. So some of those sounds don't get encoded correctly by the ear. So that what goes to the brain is garbled, and the brain has to figure out the sounds that are missing. So instead of hearing something like see before you go to your house, you lose some of those sounds, and you might hear you would go to Arma E before you eat, or you go to your owl. So you can hear already there's certain sounds that you're missing, and your brain just has to figure out what's being said. And it does that at the expense of doing other things like forming memories. One thing that I think is really interesting is there have been a number of studies, again, going back to different paradigms, so thinking of more psychology-based paradigms, where you have people who have really good hearing, the auditory signal, and then they can't remember as many words as if they were able to hear clearly. Or if you put someone in a scanner and we see blood flow in the brain, and we degrade that auditory signal, what's really interesting is you see neural networks that are now being recruited that are associated with problem solving because you're missing parts of it. So it's not just volume, it really is clarity of. So when we think about how we measure hearing, we typically do so using something called an audiogram. This is where we plot the level of hearing, so the sound, what you can hear along the y-axis, and the pitch or the frequency along the x-axis. So sounds that are really quiet and really high-pitched are in the upper right-hand corner. Sounds that are very loud and very low frequency are in the very low left-hand corner, so something like a jackhammer. You see this kind of salmon-colored shape. It's called the speech banana in a lot of countries. In Australia, it's called the speech boomerang. But this is kind of the area of the audiogram where most of those sounds that are really important for speech are located. And again, what happens in an age-related loss is not that we lose all of our frequencies. What we actually lose is our high frequencies first. So a typical age-related loss might look something like this, where everything above that line you lose access to, but you still have access to everything below. You could still hear a dog barking or a crying baby, sound of water running, maybe you can't hear. Softer sounds like the P and the H, the S sound, the CH sound, those sounds we lose. Another thing Nick taught me, many times when people who have not had hearing for a while, fit for hearing aids the first time, a lot of the things that kind of shock them and surprise them is the sound of the toilet flushing. And it can actually be quite concerning to them because they haven't heard it in so long, and now you hear it quite loudly again. So there's a lot of things that we just lose access to that we don't necessarily think about. I think there's that misunderstanding of how hearing works, that it really is clarity, not volume, but it's also a misunderstanding of what the different hearing measures are actually measuring. And we have a lot. So we kind of said, okay, hearing happens in two steps. The first is in the ear, and really the encoding of that sound happens in the cochlea, which is in the inner ear, and that's the spiral-shaped organ of hearing that's pictured here in blue. But we have the outer ear, the pinna or earlobe, the auditory canal, our middle ear as well, where we have those three bones, if you remember from high school biology as well. The whole goal of the outer and the middle ear is to take that sound, to funnel that sound, to amplify that sound, to give us the best chance of encoding it into a neural signal. When we talk about the different types of hearing loss, there are actually kind of two broad categories. John, jump in here and correct anything wrong. But we can say, think first of conductive hearing loss, where there actually is a blockage in the ear. So maybe there's fluid because of an ear infection, for example, or maybe if cerumen or earwax buildup is really strong and blocking it. That really does just dampen all sounds, but it truly is just blocking the sound. But again, the inner ear isn't just about hearing that sound, right? Getting the sound to it. It's about encoding into the neural signal. What happens in the inner ear, particularly, we have these little cells called hair cells. Those we tend to lose with age, and they are post-mitotic, they don't regenerate, which means once we lose them, we don't get them back. And those hair cells are really important for the encoding of that sound into the neural signal. We actually lose fidelity in the encoding of sound. That, again, it's the clarity issue. It's not just everything gets quieter, fidelity of sound. Just kind of summarizing peripheral transduction. The pinna and that external auditory canal, they funnel that sound to the middle ear, which amplify and transduce those sound vibrations to the cochlea. The outer hair cells are really what are so important. They amplify vibrations for the inner hair cells where we have that transduction. Something we also didn't talk about, but again, why we tend to lose higher frequencies first, is that the hair cells are arranged in the cochlea tonotopically. So you can think about it like keyboard keys on a piano. So it always goes in the same order of frequencies. And that's why you actually can see sometimes noise-induced hearing loss on an audiogram, because when noise comes in really quickly, it has that shearing effect on the hair cells. And so that typically is around 4,000 hertz. So you can actually see people's hearing is worse around 4,000 hertz, where those hair cells were damaged by that noise, just to the force coming in. But then at higher frequencies, their hearing gets. And so that really, it's that tonotopical organization that really is so important to understand. And it's not just the transduction of that sound, right? It's the decoding of that sound in the brain. The cortical circuitry that we use does vary with the type of thing that we're doing, whether it's speech, language, or music. It does occur across multiple regions, and it does occur in context with other stimuli. If you are in a noisy environment and someone has their back to you and says something, very hard to understand what they said. If they're turning and facing you and you can see their lips, now you have a better sense because your brain is also taking. So one of the reasons why I really highlight this is we're interested in understanding associations between hearing loss and dementia or cognition. It's really important for us to make sure that we're talking mechanisms that relate to that question, and also then picking hearing measures that relate to that question and the mechanism. So I have seen people tell me there's an association between measures of central processing and cognition, and my response is, of course there is. You are telling me that something that occurs in the brain is correlated with something else that occurs in the brain. Whether or not I address that won't tell me anything about whether or not I can prevent dementia. So really, when we're talking about hearing loss and cognition, what we want to be focusing on are those peripheral measures, how well the ear is encoding that sound. And then that's also the level where we have our inner. So it really is a wide spectrum, going all the way from what happens in the ear on the bottom up to central cortical function. Here I have just one example. There are so many other measures, but John would tell you and other audiologists would tell you something like OAEs, otoacoustic emissions. This is what's used in newborn hearing screening, and it truly is a biological measure. It just measures how well the hair cells are working. They're working yes, no. So you get a yes, no response, and no one has to respond. No one has to do anything. The baby can be asleep. We contrast that with something that we typically in epidemiology and public health call objective, which is pure tone audiometry, which is what we've been talking about. But if you ask an audiologist, they'll tell you this is a behavioral measure because we're playing the tones and then it asks people to respond in response to that tone. Raise your hand if you hear. What I will say though is we are able to get valid pure tones in young children. You don't even have to be able to have speech yet. There's gamification where children know they can turn to look at a toy if they hear a sound, for example. There's also been some really good work that's been conducted in people who have mild dementia. We can still get valid pure tones in there. So even though there is that behavioral and response component, I still think we can get valid measures to answer the questions we want to answer. But the importance of reliability is there. And so oftentimes in our protocols, we build in reliability where we're retesting the 1,000, sure that we are From there, we move now to something that much more involves the brain. And so this would be speech understanding. And so a lot of these measures you might see would be speech and noise, where you try to understand and hear words. This typically happens in laboratory settings to try to understand that. And then we get to the point where now we're actually reporting as an individual how we feel our communication function is, or we're just self-reporting our hearing. And of course, we can ask that in a number of ways. So we tend to think again about objective, subjective. A lot of times I think we have the bias that objective is better. I would argue that every single measure on here and a lot more of the measures that we have, they all have their place and they're all very important. Just have to understand what we're measuring and make sure it's we are really interested in someone's personal experience of their hearing loss. There's absolutely no way for us to know that unless we ask them. So if our question has to do with anything with ability or anything related to your lived experience with your hearing, we'll be asking that question, and pure tone audiometry is not going to give us that answer. If we are worried about potential sounding by self-report, again, because it is much higher ordered. It is obviously involving brain, it's involving social context. Do you need to have your hearing? Are you in noisy environments often? Or are you someone who sits at home and reads or watches the TV, and so you're not out in the environments where you will be, right? But there are differences, of course. And I showed this here because I think this comes as a surprise to a lot of people. So this is data using NHANES, so the National Health and Nutrition Examination Survey. This was, the NHANES study had both self-report and audiometry. So this is comparing responses of the same individuals who had. And overall, we were trying to understand what's the degree of agreement between self-report and between audiometry. And overall, it's about 72%. It's around 72% overall for the classification. And I have seen people in their discussions say, well, I use self-report as a hearing measure, and that's a limitation, but the correlation is 70%, so that's pretty good. We disagree with that. But then I think what is surprising for people, so in addition to saying, okay, well, what percent of people agreed? The next question is, well, among those who disagreed, how did they disagree? So did they say that their hearing was better than what we measured by audiometry? They underestimated their hearing loss, or did they overestimate their hearing loss? Did they say their hearing was worse than what we actually measured by audiometry? And it actually is pretty even. 45% of individuals said my hearing is worse than what it actually is. And again, I think that just goes to the importance of context. If we're in noisy environments because our job is to get out and talk to people in those arenas, then maybe that would be a concern for us, right? And so we might notice, for example, I think we all have the conception, especially on the public health side, that if people are getting it wrong, they're underestimating, but it's not true. It can. I do just want to point out here, if we look by the age groups, again, I think the misclassification is more interesting. If we look at that 50 to 59 year age group, we see a completely different pattern now where it's about 80% of people say my hearing is worse than what you measure using audiometry. 20% say my hearing is worse. But if we now look down at the 80-year-olds, it goes completely the other direction. It's 93% of individuals over 80 are saying my hearing is better than what it actually is, right? So we have differential misclassification by age, the risk factor for everything. In addition to that, if we look at education, the opposite story with education. So for less than a high school degree, you're likely to underestimate the degree of hearing loss, say it's better than what it actually is. Because if you have college or more, you're more likely to say that my hearing is worse than what it actually is. And education is so important. So just something to keep in mind. This is another study using the same data in NHANES, and this is now just not looking at the degree of concordance between self-report and objective measures, but instead saying, okay, I have both measures. What are my associations that I calculate when I'm looking at different outcomes? that differ based on whether the outcome is measured objectively or subjectively. So here, what I really just want you to pay attention to are the shaded areas. And so the more darkly, anything shaded is statistically significant. The more darkly shaded is more statistically significant value, so a stronger level of statistical evidence. When we look at objective measures, so this is accelerometry or hospitalization in the past 12 months, if we measure hearing using audiometry, we see associations where we do not see them with self-report. Not only are we having differential report, we're actually now having different inference based on the measure that we're choosing. If we go now to subjective outcomes, so that starts at the bottom with self-reported past 30 days. And here now the table continues. These are all self-reported outcomes. Now we see that, yeah, audiometry still shows up sometimes, but inference is really consistently there for self-reported measure. Guess what? This isn't surprising, because if you ask someone to report their hearing and ask someone to report something else related to their health, reporting it, this, there are things related to how people report the measurement error, that sort of thing, that are going to be correlated. It's not surprising that we're seeing these associations. Again, I'm not meaning to say that self-report is incorrect. What I am meaning to say, though, is that I think we cannot use self-report to approximate audiometry and call it. I think we need a number of different measures so that we can actually have the measure that matches the research we're trying. And so often I know we're stuck with data sets that have already collected the data. And so we may not have a choice, but we can at least be thoughtful about the interpretation, and we can at least couch our findings. So kind of moving on to think about how we would link hearing loss to dementia. I said we didn't know if hearing loss is a risk factor for cognitive decline and dementia causally. We still don't know that, but we do think that there are some mechanisms by which it might be associated. We've already talked a little bit about cognitive load, which is that extra processing effort you need to understand that input. Changes to brain structure and function, we've talked a little bit about as well. Reduced activity, this is cognitive activity, increased social isolation, loneliness as well as depression. Of course, we always worry about confounding and other sources of bias as well. I think what's really important to understand is all of these pathways we should be able to modify with treatment. So that really does set us up then for thinking about hearing treatment for dementia, and can we delay cognitive. So even though we've said there are these strong associations, they're consistent, there's some pathways by which we think hearing loss might be causally linked, hearing aid use is low. And so this is data again from NHANES. Depending on the study you look at, you estimate between 20 and 30% of people who have hearing loss who could potentially benefit are actually using. There's a lot of different reasons for that. I will say there's probably some good news, again, using NHATS data, that the number of people who are using hearing aids have been increasing over time, but there are disparities in people who are increasing. So it's actually white men started with the highest proportion of use and are still continuing to increase over time, versus Black women and Black men, all the way at the bottom of the figure, much less used to start with and slower increases at the time. So we have more. But even so, there have been a number of studies that have looked at hearing loss and dementia and cognitive decline and tried to understand if hearing aids modify that association. This is one meta-analysis of observational evidence where they did conclude that it was about a 19% decrease in the hazards of long-term cognitive decline among people who used hearing aids versus those who. But I think we have to be really cautious in interpreting this type of data. And so one thing we have to worry about is confounding by indication. So this is the idea that people who get treatment are more likely to get treatment because they have certain characteristics that are linked to the condition. And certainly with hearing aids, they are very expensive. We're talking about nearly $5,000 a pair. At most, they last 5 years. At least they last around 3 years. So you're talking about repeated use. They're difficult to learn how to use. Glasses bend light, so the light goes to our retina. We can correct vision impairment. We talked about damage to those hair cells. we cannot correct that damage. So hearing aids do not restore to normal hearing. I think that's something else that. But this really high cost, nearly $5,000 a pair. We have to get clearance by an EAT. We have to understand that they don't work right away and be willing to work with that. The importance of counseling is there. So there's a lot of different reasons why people may or may not adopt hearing aids, and once they have them, may or may not use them. John, I'm sure you know this too, but from other audiologist colleagues, it's in the drawer hearing aids. And so this is coming from Joe Livingston and others commenting on that meta-analysis, just saying observational findings might be confounded as those who use hearing aids might have better access to financial, social, or cognitive resources to look after their health compared to the hearing aids. And it's true. I mean, higher SES, higher levels of education, greater healthcare utilization, things that prevent. I think another really important point that a lot of studies don't realize, and there was a really important seminal study conducted in France. I think we've done incorrectly, and unfortunately it's perpetuated that, and that is actually understanding who should be the comparison group. Comparisons for hearing aid users. So of course, in epidemiology, we understand the purpose of a comparison group is to understand the excess risk. How much risk is associated with the risk factor over and above the background risk? And if we don't account for the background risk, we are going to overestimate the potential risk associated with that. So if we're talking about people here who are hearing aid users, a lot of times in the literature, what you see is compared to normal hearing. Like we've just talked about, we can't get normal hearing with hearing. Never get normal hearing. People who use hearing aids or people who have normal hearing are also not at risk for dementia because they have hearing loss. They don't. And so when we start thinking about the right comparison group, really shouldn't be a no hearing loss group, in my opinion. And unfortunately, what we get is a lot of interaction terms, and then you end up with really small numbers, really wide confidence intervals. But instead, we need to be thinking among those who have hearing loss, who could potentially benefit. Let's compare that group, the hearing aid users, to them. One thing that I've said again, like we can't restore hearing to normal or to typical using hearing aids, but hearing aids really are amazing. I don't want to downplay how helpful they can make sounds louder and clearer. They're more than just sound amplifications. Some of the things that they can do now, really even within the last couple of years, things like signal transposition. So like I said, we lose hair cells at certain parts of the cochlea, certain frequencies as we age, actually taking the signal that should have gone to a higher frequency, moving it to a lower frequency to try to help with hearing. Now, of course, there's issues with that as well, but really the devices can be quite nuanced, quite good. Some of the more recent ones, especially with the AI that they're using now, really trying to understand, again, like directionality. So really being able to hear so clear the people that you're interested in hearing, and noise reduction algorithms. There's a lot that the can do. But again, they're not a cure, which most people don't understand, and certainly a lot of public health researchers don't understand. So they really are a rehabilitation. And so we should really be talking about them in that. One caveat that I will say, that the research to date, especially around hearing aids and how well they work, is conducted in laboratory settings. We're talking about efficacy research out there in the real world still isn't there. And there's a lot of nuances, which again, I think are challenging no matter what. And it just highlights the importance of counseling and expectation management as part of overall hearing healthcare. Another thing that's really important is that people get better at using their hearing aids the more that they use them. Their brain rewires, you get to understand how they work. And so an experienced user might be used to certain cues from some of the features in the hearing aids that people who have just started aren't. And so rarely do we have hearing aid measured at all, let alone all of these kinds of how long have you used them. Duration is something we almost never have. But it's things I think we need to start collecting. Kind of going back to our timeline of the research on hearing loss and dementia, it was in 2017 that we had the pilot study for our randomized trial published. And of course, now I can't believe it, but it's been 3 years. The full findings of the ACHIEVE study have come out, and this was a multi-site study that was designed to test a best practices hearing intervention versus a health aging control on cognitive decline over 3 years. It was among older adults over the age of 74, I think was our lower cut point. And it really was among people who were not using hearing aids, had uncorrected hearing loss, and also had their cognition was not clinically impaired. I won't go into too much detail for the other methods. I'm happy to talk about them if you like, but I will just highlight, so it's unequivocally clear, the results of that trial were null, 100% null. You could not get more null. The difference in global cognition comparing hearing aid users to the hearing intervention to the education control was 0.002. Not get more null. So really in the combined cohort, the results are hearing intervention did not delay cognition. What has been discussed a lot in different settings, including in the media, is a subgroup finding. In one recruitment cohort, we had 2 recruitment cohorts. One was the atherosclerosis risk and community study, where the study was housed. It was nested within. Then the other was just recruiting de novo participants from the community. So it was in the ERIC cohort that we did see a difference where the hearing slowed cognitive decline over time by 0.19 standard deviations over the 3 years, and that equated to about a 48% reduction. So we do have findings there that are definitely worth exploring, but what I will say is we also have a lot of other really important results that I don't think have been discussed enough. So improved communicative function, I don't think that's so surprising. This was a hearing intervention. With the intervention versus the control among all participants, we saw reduced levels of reduced fall years. A really important finding is we saw lower rates of changes in social isolation, and this is across a number of metrics, including network size and embeddedness. We also saw less loneliness over time among individuals. Not published yet, and these are preliminary results. We're still waiting on the data harmonization. There are some suggestions that we might also see reductions in white matter hyperintensities over time by intervention status, as well as reduced cortical thinning. What I will say is pretty consistent with all of our physical measures, physical function, physical activity, we did not see. So kind of where we are now, it's been 3 years since those are published. We have continued to follow individuals. We have preliminary 6-year data for cognitive and social outcomes that look like they're holding. So those ERIC participants still look like they're seeing benefit. But we're not seeing any effects in the other cohort. I think there are a lot of challenges with this results trial, particularly, I take a lot of blame for this as being part of the investigative team. The way the results were rolled out, I think was confusing for people to understand because nuanced findings are hard to explain. So you get things like hearing aids may cut risk of cognitive decline by nearly half, which you're reading in the Washington Post. And this second quote is from a review I just had for a grant. Reviewer is not convinced that hearing loss is a key driver of cognitive impairment. People have decided the results are either right or they're oversold, and no one seems to think we have more work to do in this area. And I actually think we did ourselves a real disservice by focusing on so much on that positive finding instead of also balancing it with what we don't yet know. And so we really are facing some of those challenges. You know, I will say, if you take a big step back and look at it broadly, the fact that we only saw cognitive effects in a subgroup might actually be really helpful for us because there is no way you could ever get Medicare hearing aids. It may actually be a blessing in disguise, right? But we have to figure out who those people are. I think we need to understand who benefits. We need to understand our mechanisms. which I don't think we can get from trial data. We need observational data. Well, my colleagues really are supporting the idea of a new trial. I think we need to be careful with thoughts around this. Should we be looking at other interventions? Should we be looking at settings? We also need help for clinicians to talk to patients about hearing loss. It really is a mess out there. Patients are coming in and saying, I'm going to get hearing aids so that I don't get dementia. How do you handle that, particularly when you're not trained in public health? How do you? And I think a big challenge right now is the lack of understanding of that average results, which is what we get in our trials. No one is average. Average results don't apply to anybody. You have an individual patient in front of you, you have to understand their individual characteristics and whether or not that intervention. I will say there are a lot of groups kind of trying to help hearing healthcare providers. This is one group that was led by Sonova, but they really are mostly industry driven at this time. I think us in the public health research space, and I guess just kind of summarizing this up, when we start thinking about what's going on, there's a lot that's going on that we don't understand yet with this research question. And it's not just asking the right question. I think we also have to really be champions of questions to make sure it's clear why we need those questions addressed and why they're important. I know I can talk and talk. Do we have until 5 o'clock or do we want to? We do. Okay. Are you guys doing okay? It's a lot of talking, like, please feel free to get up, stretch, like do whatever you need. Like an hour and a half is a long time. Talk for longer, but. Next step. So we are now working, we have the 6-year follow-up. We are working to get funding for continuing the follow-up of the Achieve cohort for an additional 3 years. I will tell you, NIA is not interested in this. We've been 6 years out, there's no change in cognition. But who is interested in this is NIDCD. And so they're the National Institute on Deafness and Communication Disorders. They're a group who's very interested in precision audiology approach. How do we treat that individual patient and understand what their needs are? They're very, very interested in clinical translation. And we now have the largest and longest running study of hearing aid use that's ever been conducted. So I think there are a lot of really interesting and important questions that we can address related to those topics. I also think we need to continue to focus on those social outcomes. We saw such a strong signal, it's continuing to hold, that social health is. We also have a funding application submitted to try to understand other key questions that who's going to benefit, how they benefit, that we really think are necessary to move the nation. We do have collaborators from NYU who are working on a potential new trial, and then we are trying to continue those education. The findings get out there in a way that's actually useful, as nuanced as they continue. Kind of moving on, and this will be a little bit faster, but in terms of parts of the talk, but we just talked about like the importance of the research question, figuring out what's going on. We all know the research question is so important, but we also all know there's a timeliness to science. So it's not just the right question, it's at the right time. And so here, turning to the bird song, turn, turn, turn. Everything turn, 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 there is a season, turn, 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 and a time to every purpose. To illustrate this, I want to walk through, we have a very, very strong history of advocacy at the Cochlear Center for Hearing and Public Health, and it really has been led primarily by Lynn and but going back to 2011, again, that was when Frank's first paper on hearing loss and dementia was published. It was shortly after that time, so a lot of the research hadn't come out yet, that we started to see the movement on policy. So it started in 2015 with the PCAST. This is the President's Council on Science and Technology. They put out a report that recommended changes to promote innovation in hearing technologies. This had nothing to do with the research that was coming out at the time. And I think so often when we think about translating to policy and thinking about that public health impact, we tend to think it's the research that's important. And it's honestly not, it's the storytelling, right? It's that individual connection to someone you know. And at that time, our president was Barack Obama. Her father had just gotten hearing aids. And so that really motivated the council with taking up this question of whether hearing technology is important, right? Capitalizing on that, Frank led efforts with the National Academies in 2016, publishing a report on hearing healthcare for older adults. This really focused on the affordability of hearing aids. Again, they are statutory. They are not covered by Medicare, not covered by most private insurance. There are some Medicaid waivers and states that will cover them, but not really in any kind of meaningful way generally. And it really does vary state by state. And at $5,000, for a lot of people, we're talking about their third most expensive is in their lifetime, you know, house, car, hearing. So the affordability really wasn't there. The access also really wasn't there as well. So this report really focused on affordability and accessibility of care. Then in a very short period of time, folks coming across the aisle, so Elizabeth Warren and Chuck Grassley sponsored the bill that passed the Over-the-Counter Hearing Aid Act. And so this act really said now, in order to promote affordability, in order to promote accessibility, let's have hearing aids be over the counter. Before we had technologies that essentially were hearing aids, you just couldn't call them hearing aids. It'd be called personal sound amplifier. And so it really was this bill that said, let's go ahead and make them over the counter so that people really can have access to them. The idea was that you're going to get a lot more players involved, and a lot of people are already involved in music and speakers and sound and all of those sorts of things. So Bose was a leader in this area to start with, for example. And other companies as well who were really well poised to be able to suddenly now have a hearing aid that they can call a hearing aid. So the idea is if you get a lot more of these players involved, they're going to create hearing aids that are designed for the end user and are more accessible. And we were hoping the cost would come down. That still didn't take care of services, because when you purchase hearing aids, bundled with the cost of the hearing aid, it's probably why the reason that hearing aids is so high. So there was a provision in the Build Back Better bill under Joe Biden in terms of adding coverage from Medicare for those audiological services, with the idea that some over-the-counter hearing aids will work, some they will need help, but others may need help in terms of the services that have been covered. Unfortunately, this bill did not pass. It did not pass by one vote. It did not pass by one vote by a senator who typically is funded by Cole, and that year their greatest contribution was from the hearing aid industry. So some people who had interest in delay then of the OTC Hearing Aid Act was delayed a little bit because of the pandemic. But in November 2022, that's when the FDA came out with the way that they were going to govern the regulation of the OTC hearing aids. And this is, I think, where unfortunately we really hit a hiccup, as they decided that there would be a 501k exemption, which means you do not have to demonstrate that your hearing aids work, or what you said they do. You just have to show that they meet certain technical specs. Because of that, now we've seen a market flooded with low quality devices. And even now, unfortunately, all the major players except the market. So although I firmly believe in the OTC Act, and I think it's still a great idea in theory, it just highlights how important the rollout. Here I just highlight that all of this happened before. So again, it's not the research that if you're just kind of summarizing, I think the importance. So this is Sir Rodford Hill. Many of us, of course, know him, worked with Richard Dahl, key thought leaders in epidemiology, a lot of the work behind smoking and lung cancer. This is a quote that I just really like. I teach to my students every year. That's taken from his talk that he was talking about causal inference, actually. But what he said is all scientific work is incomplete, whether it be observational or experimental. Scientific work is liable to be upset or modified by advancing knowledge. That does not confer upon us a freedom to ignore the knowledge we already have. Again, I think the advocacy moved forward in the way that it really should have. The time was right. People were interested. People were coming together from across the table. And we did have evidence at the time, I think, to suggest that hearing aids, everyone, no matter what, regardless of what they did for cognition, hearing aids help older. What we have to remember, though, is like if we barrel too far ahead again, we can face those challenges like we did with the FT. This is just a line from Kenny Rogers, the gambler, saying not so fast, right? You got to know when to hold them, know when to fold them, know when to walk away, when to run. And so I'm not ready to walk away or run. But I will say, at least in early market analysis of OTC, we are not seeing success. So this is, again, published in the Wall Street Journal, the hearing aid revolution that wasn't. And that's just because most of the people who now get OTC hearing aids. The question is, once we've lost them at that point, are we ever going to get them back into? I think we have to think really. We move forward in this space of OTC. We do have current initiatives to kind of drive public health action, and so we have a Bloomberg branded, your hearing. The idea behind this is to try to set a metric to hearing. We know what our blood pressure is. We know what our weight is. Most of us know what our vision is, but we don't have a metric that's universal to allow us to talk about our hearing. So this really is a campaign that we're working on now. And what we're trying to do is understand the needs of different stakeholders and how this campaign can be useful for them. And so we're partnering with the Johns Hopkins Center for Communication Programs. They are experts in person-centered behavior change. And so they are really helping us to try to do the research, to know when to hold them for a little bit, to take a step back and not just barrel out there with this, but to make sure we're putting some research backed. And finally, I think what's so critical, and as I kind of wrap things up, I'll turn to the visuals with a little help from my friends. So you do if I sang out of tune, would you stand up and walk out on me? Lend me your ears and I'll sing you a song. I'll try not to sing out of key. So when I think about what's next, I think there are a lot of opportunities for us. Yes, we have 2 years official of more funding from Cochlear. From Cochlear, but certainly from folks as well who are interested in this work. Our training mission is central to everything that we're doing. We are in communication and discussion to think about how we might expand that training mission. There's some very targeted opportunities for our next generation of clinician scientist leaders. And specifically those leaders, once they're already kind of out there, we have our fellows program, but that's a very short time with them. So we're looking into the 1-year master's program. Certainly, I think one of the great strengths of being here at Hopkins is that we're at Hopkins and there are so many resources and so many other amazing folks. So strengthening our ties to Bloomberg and to our epidemiology. I really think we have opportunities to formalize collaborations with external networks and other groups to really kind of amplify synergies and raise our voices collectively together to make this work happen. And certainly, I think we need to continue to strengthen our advocacy efforts. And I think we can probably do that. So I'm really thinking about ways that we can strategically expand. So we will obviously continue with the training that we're doing for our students, fellows, as well as our CHAMPS programs. Again, we're in discussion for that 1-year master's program for certain mission scientists who might really benefit from this training. In terms of research, so we are one center, but there are other groups who are really interested in this work, including the Sense Network. So we are funded by the National Institute on Aging. I lead this effort with my colleague Josh Ehrlich at the University of Michigan. And the whole goal of Sense Network is to build the infrastructure to make sensory health and aging research easier. So that's really what we're working to do. And so collaborating with them about how can we match everything other sensory health. We've also been in communication with the Johns Hopkins Center for Clinical Trials to think about how we might be able to support some really promising grant applications for particularly intervention research. I mentioned on the advocacy angle, we're now partnering with the Center for Communication Programs. We are wrapping up some of that work now, and I imagine that by late summer, early fall, we'll have some next steps with that program. And then we've also been in communication with the JHU Learner Center for Advocacy. Right now, it's primarily related to our training efforts. They're another great center looking to work strategically with. You know, I started this by saying to get by with a little help from my friends, and this is just looking at an org chart for the Cochlear Center, really from, I think, one of our heydays a couple years in. Frank really was great at getting a lot of great people involved in the center. We had a number of different focus areas, but priorities change and focus areas change. And so by the time, you know, Frank left, when I took over in 2025, we really had very few faculty who are still with us anymore, very few staff who are, as you can imagine, it's really hard to make headway on any of these efforts unless you really have the people behind it. And I really view the goal of having a center, you know, the people are at the heart of the center. The idea is like, how can we bring resources together and really help that infrastructure, help that structural support to really accelerate the pace of the research. So I am really happy to say that as of now, I think we've really been in a rebuilding, but we have a lot more faculty now, a deeper bench than we used to have. I think really critically, we've brought in a lot of new expertise. So not only just thinking about the policy side or like the basic kind of epidemiologic side, but going all the way from those basic association studies to the translational epidemiology to the implementation science to be able to think about getting it into the clinic, into other areas. So I think we really have expanded the breadth of the knowledge that we have now in the center as well. Again, as I mentioned, we have these new internal partners, Clinical Trials for Evidence Synthesis, the Learner Center for Advocacy, the Center for Communication Programs. Also mentioned we have new external partners that we now are forming with, so the Sense Network. We also have a sensory health interest group at GSA. If you've not joined us, please do. I lead that work with Jeanette Mahoney. And then we also have others at the center. So for those of you who are going to AIC, there's a sensory health professional interest area that Carrie Newman helps lead with some collaborators from Canada as well. Make sure you come to all those events as well. I do highlight here the Sense Network. We're 2 years into our funding, about ready to transition into the next 3 years. And we really are divided that way. So the first 2 years was intentional as an R33, an R61. And then the next 3 years are an R33. So it's kind of an unusual mechanism. We're organized into cores around research development and mentorship, data collection, harmonization and integration, as well as dissemination and translation. And if I were to summarize, I think what we've been able to do over these first 2 years is really take a lay of the land of where we are. Again, we have to know where we are before we know where we want to go. We've done some work with the consensus building conference this year to really kind of set research priorities for the coming years. And I think what we're really now poised to do in the next 3 years is actually start acting on some of that knowledge. And I hope at the Cochlear Center, I think we're very much the same way. We've done a lot of rebuilding, and now I think we're really ready to. We also have new governance. So we have a new scientific advisory board. This is 4 members from academia and industry, meeting 2 to 4 times per year to help give me guidance on a center and where we should go. We also plan to be putting out a call for pilot project applications that the scientific advisory. Nick Reed has agreed to be the first leader of this group. And then it's a 2 or 3 year term limit. And so I do, you know, as we come to an end and start thinking about acknowledgements, I do want to thank Frank very much. I think he has been such a force in this area. He's been absolutely outstanding, responsible for me. A lot of opportunities, very generous in sharing those opportunities with those around him. We also have a lot of really fantastic faculty and staff who have been with us at the Cochlear Center and continue to be with us at the Cochlear Center. And we could not do the work that we do without any of them. I'm also very happy to say that we've been able to officially bring 3 people back in a formal capacity in different ways. So Nick Reed was at NYU for a short time. He now has moved to industry. He's at Amplifone. He's the vice president for innovation and research, I think is his title. He made up the title himself. But so he's great work there, but part of his negotiations with Amplifone was that 20% of his time was still conducting research with us. So we're very, very grateful to have him. Also very pleased to announce officially for the very first time, Dr. Allison Wong will be rejoining us in July. She had left right before the pandemic to move to NIA. Unfortunately, we know how that worked, but we're so grateful to have her back. She's been a key leader with Achieve, and is going to be, I think, so critical to helping us manage the large research portfolio center. And then Adele Goman, who is at the University of Edinburgh. She's been involved with us in various capacities over various times. With the funding cuts externally, we had to let that part of the collaboration go. We're now actually able to bring her back and provide some funding support for her to continue to be, given how much we value what she's able to do with. We've also been great and very fortunate to bring on two really outstanding new staff members this year. So Susan Nasheed. Susan is our communications person for Sense Network, and Nasheed is now helping with a lot of the administration of the center. In addition to that, we've also been really grateful and thankful to bring in a number of new faculty collaborators this year. So Andrew D'Souza, Ian Saldana, Sheree Swartz, Sabina Haberlin, and Vidya Kamath. In addition to the partnering with the other centers that I mentioned, in addition to now this more formal collaboration with the Sense Network as well. So it really does take a village. Team science is definitely the best science. And I think hopefully we are now at a stage where we really have the capacity and we're ready to move forward. Thank you for listening to me for almost an hour and a half. I'm sorry, this is longer talk than I intended it to be, but if I were just kind of summarize everything at the end, I think one thing the center has always done well, and one thing that I'm really committed to make sure we continue to do well, is to be asking the right questions at the right time.
Questions.
Yeah, short amount of time, sorry.
Really amazing talk. Loved it. Really minor question. Why do hearing aids only last for 5 years? I want them to last longer if they're going to cost $5,000.
I want them to last longer too. I wish that they would, but the technology wears out over time. I mean, there's also a life cycle. It didn't used to be that way so much, but I think now that there are a lot more advances that are happening much. The 5 major hearing aid companies in the world, and so the truth was, once you had one pair that were kind of similar to every other pair that you could get from other places, but even now it's kind of starting to change a little bit too. So I think, John, if you have anything else to add, by all means, but it's that the technology actually wears out.
You're looking at me for a follow-up.
American made.
Not in response to that. No, they're just like any tech, just like our phones, they wear out after a while, right? These are very, very tiny, very delicate circuitry that are sitting in a part of our body where there's a lot of sweat. So it's exposed to moisture as well. So if you think about that over 5 years, it's gonna wear.
And then you have people do things like drop them in various places, hide them in there.
I have a question. What about people who have had hearing loss for like longer periods of time, like people who were born deaf or experienced deafness and then grew up with that?
Thank you so much for asking that question. I really, really appreciate it. Again, I think we have to go back to the mechanisms and why we think that hearing loss might be associated with cognition or dementia. There have been a number of studies in success in school, right? And so that's part of the reason why we have newborn hearing screening, why we try to get kids in. We're able to demonstrate that. But I do not think that all of those mechanisms that I showed apply to born congenitally deaf or those who are part of the strong community. I think we certainly still face stigma and concern around the way that people are treated in certain settings, like that still exists for sure. But some of those other mechanisms don't apply. So I think we have to be cognizant of that if we're interested in answering those questions. There are a lot of people who are interested in that now, and the truth is we just don't have the data with the follow-up, I think, to those questions yet, but I would actually be surprised if we see relationships as strong. There might be something there, but again, especially with kids who are able to get treatment or learn ASL, and are in those environments, just would be surprised if we saw associations that were that strong. I don't know yet.
A quick follow-up question, like for adults who have ASL, do they have the same risk as adults who have not, just as sort of an alternative to hearing aids?
I love that question, and I don't know the answer to it. I don't know if anyone, I feel like someone must have done some sort of study, but I feel like it would be a much smaller study. I mean, when we're talking about our population studies, it's like we wouldn't have the numbers for that, so it would be very different populations you'd be selecting from. But no, that's a great question. I don't know. Think about like partners at Gallaudet, maybe for
find that older adult report that like one of their personal health care. Does it sort of get the background in the context of like all of the other health concerns that?
Yeah, that's a really, really great question. So, I mean, if you survey older adults and ask them what they're concerned about, it's dementia and vision. There are some people who will say hearing is really important to me, and it tends to be people who lost it more recently or suddenly, or there's something that they about it. But I will say generally people undervalue hearing, and so it tends to take a back seat. I was just talking with a clinician from another institute the other day, another institution, and they were kind of saying the same thing to me. They were a geriatrician, and they were saying, I have to address all these other concerns. I don't have time. Like, why should I be addressing that? At least the argument that I make to them is that it's not so much related to thinking about prevention of some of these outcomes as it is related to thinking about access to the information you are trying to get someone today. You may be prioritizing diabetes management, but if they can't hear you or understand you, and some of that communication breakdowns happens, and then they don't come back, or they're not taking their medication in the right way, those are all things that are in fact what you're both interested in, which is diabetes. Right? So, but that's just not the messaging to have out for. So I think, and that's one of the challenges I think we're facing is that, again, I think here. So it's partly why I started this talk out by saying, like, what things do you like to do, and realizing how hearing plays a role into that, how it affects you, how it brings you joy in the things that you do, and allows you to do the things that you want to do. So that's the kind of messaging that we're trying to get out there. Now it's not the general. People, once they hear that it may or may not help them with their cognition, a lot of people say, I don't mind hearing.
What does the world and other nations play regarding their policy on hearing aids and everything? How does that play compared to the US?
Yeah, so there are a number of countries across the globe that actually cover hearing aid costs, but yet hearing aid, it's proportions of people using hearing aids are actually pretty much the same. So it's not just about costs in terms of other things that are up. But it is different. There are some that there are even some that have OTC.
That was wonderful, Jennifer. At the very beginning of your talk, you advocated that sensory should be one of the core epidemiology of aging concerns. It sort of is now, and with intrinsic capacity, right?
Yeah, certainly.
And so, I was at an intrinsic capacity meeting recently at ARPA-H, and it's about interventions on intrinsic capacity. So that's good. Immediately, the conversation was, but where does sensory fit? Can the sorts of interventions we're considering, geroscience interventions, really have anything to do with that? And before you knew, it was being taken off of the table of the other measures. And so I'm just curious about your thoughts going forward. I mean, should we be looking at sensory more as a part of the whole picture of aging, or is it honestly separate and we should be thinking of separate interventions and maybe separate outcomes? I don't know what the answer is.
Yeah, that's a really good question, and I'd say I'd have to think more about it. My initial gut is that I like the integration idea. My initial thought with that again is just thinking, like, even if we're not trying to think about prevention of something else through intervention on sensory health, we can still try to improve access for everyone to whatever intervention we are giving them by intervening on sensory health. Right? And so I think that's a key thing that we don't often talk about, that we've done a little bit of work in that area, a little bit of research. Allison did some great work with that actually as part of her PhD dissertation, and actually showed that people who had hearing loss likely benefited more from the active cognitive training people without, right? Especially with the memory training. So I think there's more work that we probably need to do there. But I think it's not just a story of like we intervene to prevent cognitive decline or social isolation, but also anything else that wants to
We are at time, so if there are other questions, maybe stay
I can
after.